Welcome to the deep dive. Today we're tackling a really important topic, how best to treat narrowed carotid arteries. That's carotid artery stenosis.
Right, which is a major cause of stroke, unfortunately.
Exactly. And we're going to compare two key treatments, carotid artery stenting, or CAS, and the surgical option, carotid endarterectomy, CEA.
Yeah, these are the mainstays. Think of those carotid arteries like highways to the brain. Stenosis is like a major traffic jam building up.
Good analogy.
Yeah.
So clearing that blockage is crucial. And our mission today for you listening is to really get into the details of a landmark study that compared these two.
We want to understand what the findings really mean.
Precisely. We're drawing heavily from summaries designed for surgeons, focusing on the big 2010 New England Journal of Medicine paper on the CREST trial.
Yes, CREST. Stenting versus endarterectomy for treatment of carotid artery stenosis. A huge deal in the field, brought et al.
So let's start with how they even set this study up. The design is pretty key, right?
Absolutely. You need to know how they got the results to understand the results themselves.
Okay, so CREST was what they call a prospective, multi-center, randomized trial.
Which basically means they planned it out beforehand, enrolled patients at lots of different hospitals, and then randomly, like flipping a coin, assigned patients to get either the stent or the surgery.
And it wasn't a small study there.
Not at all. A whopping 2,502 patients. That large number gives the results, a lot more statistical power.
And these patients had either symptomatic or asymptomatic stenosis. Can you break down what that means for us?
Sure. Symptomatic basically meant the patient had already had a warning sign, like a TIA, a mini stroke, or a non-disabling stroke within the last 6 months, about 180 days.
Okay.
And critically, they had significant narrowing confirmed by imaging, generally over 50% on angiography or over 7% on ultrasound or other scans.
And asymptomatic.
Asymptomatic meant either no symptoms ever or any previous symptoms happened more than 180 days ago. Same artery narrowing criteria, though.
Got it. Were there people they specifically couldn't include? Exclusion criteria?
Oh, definitely. They had to exclude people where the comparison wouldn't be fair or safe. Things like a prior disabling stroke, a very recent heart attack, or unstable chest pain, unstable angina. Conditions that might heavily skew the risks of either procedure.
Right. Makes sense. Okay, so let's talk about the actual procedures in the trial. What did the surgery group, the CEA group, experience?
Well, the surgeons mostly did what they normally do in practice. That was kind of the point, to reflect the real world. About 90% used general anesthesia.
Okay.
Often they'd use a patch to close the artery after removing the plaque, and sometimes a shunt, like a temporary bypass tube, during the operation. And afterwards, standard practice, aspirin.
And the stenting group, CAS, what was the protocol there?
That was done via catheter, usually through the groin, the transfemoral approach. The protocol specified using the Acculink stent system.
Right.
And importantly, they almost always used a filter device too, the AccuNet filter if possible. That's designed to catch any little bits of plaque that might break off during the stenting.
Protection for the brain.
Exactly. And a key difference here, the CAS patients got dual antiplatelet therapy. So aspirin plus another drug like clopidogrel, both before and after the procedure.
Okay, that is a notable difference in medication.
Yeah.
And everyone got standard medical care otherwise.
Yes, absolutely. Standard stuff for blood pressure, cholesterol, diabetes, whatever else they needed. That was consistent across both groups.
And they followed these patients for a decent amount of time.
Yeah, the first big paper reported on about 2.5 years median follow-up. Long enough to see immediate issues in some of the medium-term outcomes.
Okay, let's get to the main results then. What was the primary question, the main thing they were measuring? The primary endpoint.
Right, the primary endpoint. It was a composite, so they combined a few bad outcomes into one measure.
Okay, what was in the mix?
It was any stroke, any heart attack MI, myocardial infarction, or death from any cause during the procedural period.
The time right around the treatment.
Exactly. Or any stroke on the treated side, an ipsilateral stroke happening anytime within the next 4 years.
Combining stroke, heart attack, and death. That seems broad.
It is, and that's something we'll definitely come back to. Using composite endpoints like this is common in trials, but, whether a heart attack and a stroke carry the same weight for a patient, that's debatable.
A very important point. But first, what did the study find for that specific combined endpoint?
Okay, so over the 4 years, the rate of that combined event was 7.2% for the stenting group and 6.8% for the surgery group.
So very close numbers.
Extremely close. And the crucial part, that difference was not statistically significant. The p-value was 0.51. way above the usual 0.05 threshold.
Meaning they couldn't confidently say there was a real difference based on that measure alone.
Precisely. And they also found no difference based on whether patients started out symptomatic or asymptomatic or based on sex.
So the headline from CREST, based on the primary endpoint, was essentially equivalence.
That was the initial take, yeah. That stenting and surgery look pretty similar for this combined outcome, but like you hinted, we need to unpack that.
Yeah, let's dig deeper. What happened when they looked at the individual parts of that composite endpoint? Stroke, MI, death, separately. This is where it gets really interesting, doesn't it?
Absolutely. This is critical. When you look at the peri-procedural period, that time right around the treatment, there were significant differences.
Okay.
The rate of stroke during or soon after the procedure was significantly higher with stenting. It was 4.1% in the CAS group versus 2.3% in the CEA group.
Wow. Okay, nearly double the risk of stroke around the procedure time with the stent. That's significant. P-value was low.
Yes, p-value 0.01, so statistically significant.
Okay. What about heart attacks, MIs?
That's the flip side. The risk of periprocedural heart attack was significantly higher with the surgery. It was 2.3% for CEA versus 1.1% for CAS.
Also statistically significant.
Also significant, yes. P-0.0 for that comparison.
So a trade-off right there in the immediate aftermath. Higher stroke risk with stenting, higher heart attack risk with surgery. What about death?
Periprocedural death rates were low overall, thankfully. 0.7% with stenting, 0.3% with surgery. That difference wasn't statistically significant. P.18.
Okay, so the main statistically significant differences early on were stroke favoring surgery and MI favoring stenting. What about strokes later on after that initial period?
That's also fascinating. After that periprocedural window closed, the risk of having a stroke on the treated side later on was actually very low and very similar between the groups.
How similar?
About 2.0% for stenting versus 2.4% for surgery over the remaining follow-up time. No significant difference there at all.
T0.85.
So it really seems like the procedures differed most in their early risks. The long-term stroke prevention looked comparable once you got past that initial phase.
That's a fair summary of what the CREST data showed, yes.
Now, you mentioned expert commentary is important. Our source material includes insights from Wesley S. Moore, a big name in vascular surgery. What was his take on CREST? Did he have critiques?
He did, and they're quite pointed, focusing right on that primary composite endpoint we discussed.
Moore basically argued that lumping death, stroke, and MI together implies they're equally bad from the patient's viewpoint. And he strongly felt that, particularly in this context where you're trying to prevent stroke, they are absolutely not equal.
Yeah, I can see that. I mean, preventing a stroke, especially a disabling one, feels like the main goal here. A non-fatal MI, while serious, might impact quality of life differently.
Exactly his point. He highlighted that the combined rate of death or stroke around the procedure was almost twice as high with stenting compared to surgery and CREST.
Can you give us the raw numbers again?
Yeah, in that periprocedural period, the CAS group had 9 deaths plus 52 strokes. The CEA group had 4 deaths plus 29 strokes.
That really puts it in perspective.
It does. And Moore noted the only individual outcome that favored stenting was non-fatal MI14 events in the CAS group versus 28 in the CEA group.
So Moore's argument is, if you prioritize preventing death and stroke, the data looks less favorable for stenting despite the overall composite result.
That's the core of his critique. He felt the composite endpoint kind of masked this important difference in the types of complications.
Did he propose a different way to look at it?
He did. He suggested using a penalty point system, trying to weight the outcomes based on their likely impact on a patient's life, using some quality of life data from the SF-36 questionnaires given to CREST patients.
Okay, interesting approach. How did the points work?
He assigned the most points to the worst outcomes. 10 points for death, 8 for a major stroke, 7 for a minor stroke, and 5 for an MI.
And why only 5 for an MI?
He mentioned that the questionnaire data actually showed that by 1 year, patients who'd had a periprocedural MI didn't report significantly worse physical or mental well-being compared to those who hadn't. Stroke, however, often has much longer-lasting effects.
That's quite revealing about patient experience. So applying this penalty system to the CREST data, what was the result?
It tilted the scales quite dramatically. The total penalty score for the stenting CAS group was 535 points. For the surgery CEA group, it was 391 points.
Lower is better here, right?
Lower is better, yes. And this difference, unlike the primary endpoint, was highly statistically significant. P less than 0.0001, strongly favoring surgery when weighted this way.
Wow. Okay, so that alternative analysis really paints a different picture, emphasizing the impact of stroke and death.
It certainly provides a different lens through which to view the same data, and it helps to also look at CREST in the context of other similar trials, right?
Absolutely. Context is key. Our source mentions two others, EVA3S and ICSS. What do they find?
Okay, so EVA3S was a French trial, also randomized, but focused specifically on symptomatic patients.
A higher risk group.
Generally considered so,
Yeah.
yes. And EVA3S was actually stopped early
Why?
because the trial's safety monitoring board saw a significantly higher rate of stroke and death occurring in the stenting group compared to the surgery group. It was deemed unethical to continue randomizing.
That's pretty dramatic. Did the difference hold up long term?
Yes, even at 4 years follow-up, the combined rate of death or stroke remained significantly higher in the stenting arm, mostly driven by those early peri-procedural events.
Okay, so EVA3S sounds like it showed a clear disadvantage for stenting in symptomatic patients, at least regarding stroke and death. What about ICSS?
ICSS, the International Carotid Stenting Study, was another large trial also involving symptomatic patients. It also found a higher risk for stenting compared to surgery within the first 120 days.
What specific risks?
The composite of stroke, death, or procedural MI was significantly higher with CS, and ICSS particularly noted a higher risk of major stroke with stenting early on.
So putting it all together, CREST's main finding of no difference. Moore's critique and penalty points highlighting higher stroke death with CS, plus EVA3S and ICSS also showing higher early risks, especially for stroke, with CS. What's the big takeaway message for you?
I think the takeaway is that while CREST's primary composite endpoint suggested equivalence, that headline might be misleading if your main goal, or your patient's main goal, is minimizing the immediate risk of stroke or death.
Right.
When you look closer at the components of that endpoint, and when you consider the results from EVA3S and ICSS, particularly in symptomatic patients, there appears to be a consistently higher peri-procedural risk of stroke, sometimes major stroke, associated with stenting compared to surgery.
Even though the long-term stroke prevention seems similar after that initial period in CREST.
Exactly. The price for that similar long-term outcome seems to be a higher upfront risk of stroke with CAS, potentially offset by a lower upfront risk of MI compared to CEA.
So it's really about understanding that risk profile difference. It's not that one is universally better, but they have different patterns of risk, especially early on.
Precisely. And as Moore argued, if stroke prevention is paramount, then the higher peri-procedural stroke rate with stenting is a serious factor to weigh. How you weigh those different risks, stroke versus MI, is crucial.
It highlights that tension, doesn't it, between the simplified headline result of a major trial and the more complex reality underneath when you dissect the data and compare across studies.
Absolutely. It shows why just looking at the p-value for the primary endpoint isn't always the full story. You need to understand what went into that endpoint and what the individual components showed.
So a final thought for you, our listener, to ponder. How should we really weigh these different complications? Is a heart attack equivalent to a stroke in the context of preventing brain injury? What does equivalence in a trial truly mean when the types of risks differ?
These aren't easy questions, but they're vital when making sense of medical evidence. And if you want to go even deeper, looking up the original CREST paper and maybe the EVA3S and ICSS publications too would be a great next step. They offer a wealth of detail.